Good morning or good afternoon, depending upon where you are. This is Dr. Timothy Yates, reaching out for the NCVH Digital Education Series from South Florida with the CLI Vascular Specialists of Palm Vascular Centers of Florida. Today, I'm going to be discussing cases, specifically techniques, and a small background on DVT therapy in modern endovascular medicine. These are my disclosures. So venous thromboembolism is a common disease with high annual incidences both in Europe and the United States, with multiple deaths associated with its more devastating sequela being pulmonary embolism. $10 billion spent annually for related costs to DVT management and its sequela. And despite this high incidence and prevalence, DVT therapy has not changed very significantly over the past 50 years, with anticoagulation continuing to be considered the standard of care. We do see DVT rates as well as pulmonary embolism rates do tend to increase overall with age, as does the severity of the disease findings. And as mentioned, anticoagulation has long been the standard of care. And the most recent CHEST guidelines for management of DVT are easily accessible online, and I won't go into great depth on those, but a few highlights include the novel anticoagulants such as Xarelto, Pradaxa, Eliquis are the recommended treatment. Isolated DVT in the calf veins typically can be observed with imaging over a 2-week period unless there are other risks for extension or other severe symptoms. Unprovoked or provoked leg DVTs are generally treated the same, or we treat for 3 months and then reassess the need to extend that over to 12 months. IVC filters are generally not recommended unless there's a contraindication to anticoagulants. And the guidelines do not recommend catheter-directed thrombolysis as a primary therapy, although this is only a grade 2C recommendation. What about compression therapy? Well, in the superficial venous world, this is the standard of care for management of venous hypertension, but there's no clear role established in DVT despite their regular use. Multiple trials have actually demonstrated no significant reduction in post-thrombotic syndrome rates when we use these in a supervised fashion. So generally speaking, these are used at the MD discretion and based on patient preference. A couple of trials to look for, the SOX and Octavia trial will speak to this for the reader. So briefly, before we go into cases, we're just going to talk about a few definitions and the way that I look at lower extremity venous anatomy. Proximal and distal nomenclature is splattered throughout the guidelines, but can be somewhat confusing. So I will probably refer to anything related to the IVC or the iliac veins as being central, and anything being below the groin being referred to as a peripheral. Unfortunately, the ACCP or the CHEST guidelines doesn't use this nomenclature. And these are just a couple of indicators of what I mean by central versus peripheral. Now, lower extremity DVT does tend to occur slightly more commonly in the left lower extremity, although bilaterality is still the most common. We tend to see isolated disease above the inguinal ligament and very few and less so in the iliac segments. Generally speaking, the mechanism is thought to, as you will probably hear from some of the other speakers, to be related to poor clearance from venous valves, which then results in clot and then ultimately propagation of that thrombus downstream. And interestingly, there's an interesting crossover from patients with symptomatic DVT. Several of these patients, up to 40%, will actually have an asymptomatic PE. Patients with symptomatic PE will often have an asymptomatic DVT, and a patient with a central or iliofemoral DVT, the large preponderance of those do have an associated PE. So the point of this slide is just to simply point out that really where there is one, there is generally another. And for those of us who are aggressive DVT interventionalists, it really behooves us to make sure that we look before we start to intervene on these patients to make sure we don't have any more central disease in the pulmonary vasculature. So post-thrombotic syndrome is what we'll really focus on in DVT management, and the reason we're treating a lot of this disease. It's the under-recognized but very common dreaded last consequence or end-stage disease of DVT, resulting in valvular incompetence, blood pooling, fatigue, venous hypertension, similar to what we see in superficial venous disease, and ultimately can result in ulceration and even limb loss, much like we see in arterial critical limb ischemia. And standard of care has generally been anticoagulation, which stabilizes clot, but does not prevent new thrombus. So we need to have mechanisms to treat that. We know patients with advanced post-thrombotic syndrome do have a reduced quality of life. As you've seen, very high expenditure nationally and internationally for DVT management. And over 50% or so patients will actually develop post-thrombotic syndrome somewhere along its spectrum within 2 to 5 years of initial DVT. So it's half of people will develop it, and we still don't have a great mechanism to prevent it once a DVT has been formed. So we still need better longitudinal data. Some of the more common risk factors here will lead to the most severe variety of post-thrombotic syndrome. So these are the patients we really need to aggressively intervene upon. So some of the data, very briefly, the Paget trial was instrumental in demonstrating a reduction in post-thrombotic syndrome rates in patients who underwent catheter-directed thrombolysis for iliofemoral DVT, an absolute risk reduction of about 28% at 5 years, which really was one of the major trials spurring on further development of alternate treatments for DVT, including a mechanical thrombectomy and single-session approaches. The Paget trial is a similarly designed trial that continues to enroll. The meta-analysis from Liu in 2017 also looked at a similar question about catheter-directed thrombolysis, which did demonstrate improved patency in iliofemoral vein reconstruction, as well as decreased severity of post-thrombotic syndrome when we compared that to anticoagulation alone. So this is an impetus for us to continue to try to develop interventional techniques for clot removal. The Pearl Registry looked at patients and tried to evaluate the question comparing mechanical thrombectomy with the angiojet device, which is a rheolytic thrombectomy device, compared to anticoagulation and catheter-directed thrombolysis. And as one of the conclusions is that they did find, in fact, that pharmacomechanical thrombectomy/thrombolysis may actually reduce the need or duration of traditional catheter-directed thrombolysis. So this, again, was some support for us to use a single-session approach as opposed to catheter-directed thrombolysis alone. So while I will not go into great detail on the ATTRACT trial because some of our other excellent panelists have talked about this, a couple of important points bear us in mind here. The open vein hypothesis was one of the main tenets of the ATTRACT trial. The questions were whether or not removing a significant amount of thrombus would reduce post-thrombotic syndrome rates, whether active elimination of DVT ultimately prevented it at all. And there were some support from prior studies linking poorer outcomes with poor thrombus clearance, leading to long-term valvular dysfunction, recurrent venous thromboembolism, residual venous thrombosis, or valve incompetence in post-thrombotic syndrome, and even found with systemic thrombolysis, surgical thrombectomy, or catheter thrombolysis that they tended to reduce post-thrombotic syndrome. So the question was, if we went forward with a mechanical thrombectomy single-session approach, would that, in fact, lead to post-thrombotic syndrome reduction? And ultimately, it did not. As we have heard, we did find a reduction in the severity, duration, and in the moderate severe post-thrombotic syndrome classes with patients who underwent mechanical thrombectomy versus anticoagulation alone, but overall was a negative trial when asking the primary question of whether or not we were going to reduce post-thrombotic syndrome rates. And really, ultimately, one of the other take-home points from the study is that we found that the older population, over 65, generally had a higher complication rate. It didn't seem to benefit, which has been borne out by other trials, such as the Paget trial that we previously mentioned. So briefly, we're going to touch on the devices before we touch on the actual cases. Catheter-directed thrombolysis can be performed with a variety of different types of catheters and can be done over the course of 24 to 72 hours and does require a continuous infusion. Pharmacomechanical rheolytic thrombectomy with the Boston Scientific angiojet device uses saline jets, which can be combined with TPA to generate high-pressure gradients, which allow, based on the Bernoulli principle, these eddy tides to help to not only to impact the thrombus by penetrating thrombus with TPA, but also to mechanically disrupt it so they can be mechanically aspirated at the same exact time. The Penumbra Indigo system is an aspiration thromboembolectomy system, which uses anywhere from 3 to 8 French catheters with a near vacuum thrombectomy system. The largest being the 8 French and the most commonly used for DVT management. As you can see here, a couple of cases where an IVC filter that we'll talk about later had residual disease, which is treated with thrombectomy and can be used in a combination with the separator wire to help macerate and clear the end of the catheter. The AngioVac device requires a veno-venal bypass and is a larger bore system, but does allow significant retrieval of tumor thrombus, extending from renal veins, from hepatic veins into the right atrium, and even large PEs for patients who have unstable, massive, or high-risk PEs. And more recently, the Inari clot retriever and flow retriever devices apply a stent retriever type system, as well as a larger bore aspiration system to remove clot in high proportions. So upper extremity DVT is a smaller proportion of DVT that we see, but does tend to occur largely because of intravenous catheters. The primary upper extremity DVT, or Paget Schroetter, is what we refer to as venous thoracic outlet syndrome. Tends to happen in younger patients, but can happen in older patients with repetitive injury. Secondary DVT is most commonly associated with AICD or central lines. So we can see in this trial, 93% of upper extremity DVT were related to actually having a catheter. So as we see our dialysis patients with more catheters, this is going to become more common. And finally, as we progress now toward the cases, compression syndromes are what we're going to see to a great deal in the lower extremity. In our arterial side, when we see a stenosis, that will generally result in ischemia and long-term atrophy because of lack of nutrition and metabolic products downstream of the occlusion. In a vein, the stenosis also can result in ischemia and inflammation, but for different reasons. A couple of cases here of a May-Thurner lesion, which was previously treated, and a typical venographic finding of a May-Thurner, which we'll see borne out in a couple of the cases. Here, this involves back pressure, which really involves everything upstream as opposed to what we see downstream in critical ischemia. So the first case, we're going to start with a 66-year-old gentleman who had prior right lower extremity iliofemoral DVT and severe post-thrombotic syndrome, and now left lower extremity edema. So as you can see in this prone venogram, we see a significant disease involving the right external iliac to common iliac junction. We also see a tangled mesh of veins in the left groin with no clear iliac outflow. And so in summary, this patient had previously had an IVC filter placed, a permanent filter, extensive collaterals, and severe left-sided stenosis. And what are our options? Well, this could certainly be treated conservatively, although he's failed. That's why he's here to see us. Surgery is not really a valid option here. Venous bypass patency rates are quite poor. And so an endovascular approach is really the way we're going to approach this. So let's see how we tackle this. At this point, what we basically did was come from the right side and cross that iliac lesion. And as we did, as you can see here, the wire just really deflected off away from that, from the left-sided common iliac. And so there was no way to re-enter. So the decision was made to place a large balloon in the left common iliac and use an outback device to puncture into that balloon, advance the wire. And we were ultimately able to then stent both sides, maintaining the iliocable confluence as well as the IVC with a complete recanalization. And this is another more recent patient of mine, an 83-year-old female who I saw in my office, who had additionally had a permanent IVC filter, had bilateral iliofemoral DVTs in the past, with severe post-thrombotic syndrome. As you can see, severe hyperpigmentation, swelling, lipodermatosclerosis, and those contractures around the ankles. So here you can see on venograms, we have really no clear common femoral or iliac vein outflow. And had extensive obturator and lateral circumflex collaterals, basically draining the lower extremities. So again, conservative care is an option, but was failing in this patient. Surgery, again here, patency rates not great. She has a filter. So an endovascular approach is how we're going to tackle this. So we obtained wire access on both sides. And as you can see here in our video clip, we were able to get up and around crossed bilateral iliac segments with stiff wires. After we were able to do that, IVUS was crucial in sizing the iliac veins as well as the IVC through the area of the stenosis and occlusion. After extensive angioplasty to try to break up some of those adhesions, we were able to then place bilateral wall stents, and you can see the venous outflow now is completely reconstructed. We actually stented through that IVC filter. Removal would have been an option with more complex removal techniques. We actually were able to do this completely in the office, and the patient has had significant reduction in her swelling, is now walking and free from pain. This was a 36-year-old female that had severe left lower extremity swelling, bilateral shortness of breath, and anemia that she had from recurrent vaginal bleeding. And when we examined her by CT as she came through the ER, you can see she has a very large fibroid uterus. And we can actually see a distended left-sided external iliac vein compared to the right side. Although she did not have a DVT at this time, she did have a PE on an additional CT pulmonary angiogram. So options for this patient, well, anticoagulation is relatively contraindicated or absolutely contraindicated because she's anemic, having a shortness of breath, does have PEs, but needs to have some treatment. So ultimately, because of the anemia, we did not anticoagulate her. So we did actually decide on starting by placing an IVC filter and then determining what the next steps would be. In terms of her vaginal bleeding, a hysterectomy would be a potential fix, but not feasible for her because she was uncertain whether she wanted to have children in her future, and additionally did not want to have surgery. So the UAE, or uterine artery embolization, as an endovascular means of stopping the bleeding, is another option that's on the table. So this is her venogram, and as you can see, she has extensive collateralization from the left side from the jugular approach, and you can actually see that classic May-Thurner type compression. But she also had a very large inferior vena cava. She actually had a mega cava. So a classic IVC filter, a removable filter, was not going to fit there. So we decided to place bilateral common iliac vein filters, and we'll proceed on to the next part of it. And I won't talk too much about May-Thurner syndrome simply because we've discussed this, but we did elect to do an elective uterine artery embolization, which immediately caused complete cessation of her vaginal bleeding. Transfusions then helped to raise her hemoglobin to acceptable level, which was stabilized, at which point we elected to restart her anticoagulation. After that, we went forward with iliofemoral reconstruction. As you can see here, we only needed to stent the left side. She did have a residual mild narrowing here, but had excellent flow, had complete resolution of her edema, and has not had a recurrence of DVT or PE to the date. So just a quick tidbit about endovascular ultrasound. In my venous practice, as is all the panelists for the venous section here, I presume are probably intravascular ultrasound zealots, or useful or were usable, simply because you really get real-time imaging and direct evaluation of the intraluminal structures as well as the surrounding structures. Sizing and flow are also a couple of things that are extremely useful in real time when we're treating patients. A couple of trials, one to know salient points from the video trial, found that IVUS picked up significantly more lesions than venography. We also found that in a post-thrombotic patient, a 50% lesion is the one that we need to treat. And in patients who have non-thrombotic disease, we can actually take that up slightly higher to 60 to 61% was the cutoff for where we started to see improvement post-procedure. So this is a 62-year-old gentleman with a 3-day history of travel from Cuba and prolonged dehydration, presented with severe left lower extremity edema, and found to have antiphospholipid syndrome in his workup, in addition to acute left leg DVT from his IVC all the way to his popliteal, which you can see here on this CAT scan, this long thrombus extending all the way into the cava, almost up to the renal veins. And this is his venogram, and because of the extent of the disease, the question becomes, how do we approach this? Is thrombectomy reasonable, or do we need to use thrombolysis? Well, because of the extent of his disease and how high it went, I was concerned about embolization, whether we use thrombectomy or thrombolysis. So we did place a filter above the thrombus, and we elected to do thrombolysis in order to debulk that disease. And then that filter was ultimately removed after that thrombolysis was done. And we were able to reconstruct his IVC and remove the filter, as you can see here. And now while there is some residual disease in the common femoral segment, this had excellent outflow and has stayed open. And he continues on Coumadin for his antiphospholipid syndrome. So here's a 69-year-old female with acute onset of left lower extremity edema, similarly found to have left leg DVT from the IVC to her popliteal vein. Interestingly, she did have a past history of right-sided DVT, but had been treated appropriately and was now off her anticoagulation. This is her venogram, which demonstrates what looks like relatively acute appearing femoral and popliteal DVT, but more chronic appearing iliac and caval segments when we come from below. we did elect to place an IVC filter. This is the cavegram demonstrating the cavus patent. And because the disease was relatively acute, we elected to treat this actually with a thrombectomy single section approach. And that was because the disease was relatively confined to the femoral popliteal segment in terms of acute disease, which was treated with the angiojet Zolante, in addition to a 30-minute dwell time of TPA to allow the clot to become biochemically activated prior to thrombectomy. And this is her completion. As you can see, complete recanalization, and subsequently we removed that IVC filter. Again, these are her IVUS images demonstrating her common iliacs before and after stent deployment. You can see significant improvement near normal area for the left common iliac, almost just to the 150 millimeter square that we typically deem normal. And similarly, a normal diameter for and cross-sectional area for the left common femoral vein. So in the interest of time, I'm going to pause here for just a second, guys, and I'm going to go forward on a case. Okay, this is a 79-year-old gentleman with a history of DVT in the past, and an IVC filter that had been previously placed 2 years ago. He came in with left lower extremity edema after a long trip in Thailand where he was on a yoga retreat, essentially, and was doing anywhere from 12 to 18 hours of yoga daily. And then he had a very long flight home, and he came in with significant swelling. As you can see on his prone venogram, extensive acute thrombus in the femoral popliteal segment, and again, that classic chronic-looking Seneca type appearance in the iliac segment. And if you see on the IVC filter, you can see a large glom of thrombus on top of that. So again, because of the extent of disease, thrombolysis was chosen after a suprarenal filter was placed. This is the follow-up venogram demonstrating complete recanalization of the iliofemoral segment, but still residual disease involving the IVC filter. And the decision was then made to treat this with aspiration thrombectomy with the penumbra indigo system with the separator wire. We were able to clear about 95% of that thrombus and recanalize the IVC, and subsequently the suprarenal filter was removed. And this is his post-procedural IVUS venogram and post-stenting, as you can see, all the way up to the suprarenal filter. One of my favorite patients of all time, 84-year-old female with a prior femoral popliteal DVT on the left side, but GI bleeds, so we couldn't anticoagulate her. So I did place an IVC filter, and as I followed her, she had significant worsening in her left lower extremity edema and severe pain, but in that period had no further GI bleeds. So we elected to try to place her on anticoagulation, see how she did. And she actually did quite well. So because she had severe pain and swelling, we elected to recanalize her femoral popliteal and iliofemoral DVT. And these are just some technical videos showing how we cross these lesions with the wire traversal technique, just showing that it's relatively easy to get through. And this is an important technique when we're using aspiration thrombectomy, because when we use aspiration thrombectomy with the penumbra indigo system, as you can see on the screen left, we need to have the ability to move that catheter freely within the vein and use that catheter angle to scour the surface of that vein, which allows for almost complete clearance of that thrombus. And as you can see on the completion venogram, completely reconstructed iliofemoral segments, and with the amount of thrombus we were able to remove, we were able even to create some clot art for her, as she was from the country of Colombia. This is just a case showing the Inari system, the suction thromboembolectomy system from Inari, which was used or was performed by my former partner, Dr. Brendan Olivieri, at Mount Sinai in Miami Beach. An excellent case of a May-Thurner lesion, which was revealed here after thrombectomy and treated with an iliocaval stent with excellent result. So to conclude here briefly, we're going to cover a couple of upper extremity cases just to show that the techniques are quite similar. This is an 80-year-old female long-term smoker with bronchogenic carcinoma, an SVC syndrome, a large tumor, and as you can see here on her venogram still, you can see she's got extensive thrombus and a very severe stenosis in the SVC. We were able then to treat this with a similar approach by crossing with the wire and then aspirating, as you can see here, crossing into the thrombus and removing that. We were able to completely reconstruct her SVC. And unfortunately, the video is not working, but we were able to stent that completely open. A very similar case of another gentleman with completely occluded SVC innominate veins related to the prior ports, etc., and the pacemaker electrodes, which was completely reconstructed with with thrombectomy, as well as a fluency stent for the SVC. Well, this will conclude our session for today on DVT cases. I hope it was useful. It's been a pleasure to be able to present this for NCVH and Dr. Walker. It's been a pleasure to be partners in the past several years, and we look forward to more engagement with digital media as well as our social media and live conferences as we get back in. Everyone stay safe. Please take down any of my information and reach out to me directly. I'm happy to help you if you have any questions. Thank you very much.